Hello everyone. Today we'll discuss a very important topic, fracture healing. And while dealing with fracture healing, I'll go slightly in depth because it's a topic that's very important for our theory exams. Yes, for practical when you are presenting a case of say chronic osteomyelitis or case of non-union, even while you are operating or maybe discussing with a friend of a case, say femur fracture, femur neck fracture, scaphoid waist fracture, or maybe a diaphysis of the fifth metatarsal. Right, these are, or even talus fracture, though rare. These are fractures which are prone to non-union. We'll discuss what non-union is, how does it present, and how actually do you distinguish between a delayed union or a non-union. So starting with fracture healing, and we also should know how to approach when a question, howsoever the examiner might tend to trick you, howsoever he might tend to ask the question in different ways, the way of answering doesn't change much, right? Fracture healing, the traditional teaching is fracture healing. Okay, you should know and classify the fracture healing into four stages: inflammatory, early callus, what we call soft callus, hard callus, and then remodeling. That is something everyone does. While we are answering the theory question or the Viva, our answer has to be slightly different, right? So that to have an edge over others. So what we will do, we will classify fracture healing as primary healing, primary or secondary. Now, most of you would be saying, okay, we know this, tell us something new, right? Gen Z generation, most of them. So yes, we all know that primary and secondary. Now, but primary healing is also of two types. Now, what exactly is primary healing? Primary healing is bone is opposed to each other. We have achieved a good amount of interfragmentary compression is achieved, and we tend to achieve absolute stability. And there is hardly any role of callus here, right? But majority of fractures that occur in our bones, they unite by secondary healing, and hence the system that you read, inflammatory phase, or early or soft callus phase, hard callus phase, and then remodeling phase, it pertains to secondary healing. But there are fractures, diaphyseal fractures, maybe Galeazzi fractures, humeral shaft fractures, femur shaft fracture. When you do plating, you tend to achieve absolute stability. That is primary healing. Now, primary healing in itself is of two types. If the gap between the fragments is say less than 1 mm, or if the gap is between 1 to 800 microns. So you can write it in this way, and then you can go to secondary healing. We'll discuss which of the markers or components are involved at the cellular level. We will also discuss them, because mentioning them, even if you don't know exactly which markers or inflammatory mediators are involved at which stage, even if you don't mention them, it's all right. But mention them that they are involved in the healing process. You don't have to mention each and every of them at which particular stage, which one are involved. But if you do though, if you do so, it's very good. Now, secondary healing, you all know, inflammatory phase. It lasts generally 1 to 7 days. The host has to be immunocompetent. If he is not immunocompetent, this phase is compromised, and the compromise of this phase eventually leads to the compromise of the whole process of fracture healing, isn't it? Now, inflammatory phase is mediated by a lot of markers, cellular markers. Initially, neutrophils will come, and then the macrophages will come, right? Now, the macrophages in themselves are of two types, what we call M1 macrophages. M1 macrophages. They have a tussle, just like SRH versus CSK, M1 versus M2 macrophages, right? So these M1 macrophages, they are pro-inflammatory. These M2 macrophages, these are anti-inflammatory. So for me, M1 is SRH, M2 is CSK, right? CSK are anti-inflammatory. But initially, what you want SRH, that is M1 macrophages. Later on, Dhoni's team, and Dhoni's your fan, you are a fan, and hence you want M2 macrophages to override, right? So these two are very important. Initially, M1 will increase, later on, M2 will increase and tend to balance. Now, there are other mediators also involved. When will they involve? Later on. Initially, you will have interleukins, you will have VEGF, vascular endothelial growth factor, you will have PDGF, right? Platelet derived growth factor, you have fibrin, you have platelets, you have platelet derived proteins, right? That all of these form what? Hematoma. Hematoma is not only a passive coagulum. You have to mention it. Hematoma, this word is very important, because we tend to tell you while you're operating on a, our seniors used to tell us that don't disrupt the hematoma, let the hematoma form, because it's not only a passive coagulum, it has nutrients that help in healing of the bone, right? Now, after hematoma, these hematoma will lead to the eventual formation of what we call soft callus. Soft callus will eventually give way to hard callus. Now, the stage of soft callus is very important. Soft callus. You must all know that there are two types of secondary healing, or say secondary ossification. One is intramembranous, other is endochondral. Now, which is the most common one and which occurs during stress conditions? These two. You have to mention it while writing a question on fracture healing. See, under normal conditions, when the host is not hypoxic, he has sufficient nutrition and everything, hemoglobin is adequate, there is no higher lactate levels, there is no base deficit as such, pH is normal, you'll have ossification via intramembranous ossification process. But if there is hypoxia, in conditions of stress, there is hypoxia. If there is hypoxia, you'll have increased hypoxia inducible factor, HIF alpha. What will it do? It will lead to increased VEGF, right? That will eventually lead to progression to chondrogenic phase. Initially, cartilage scaffold will be formed, and then that will lead to formation of eventually osteoblasts. Right. This is different from the normal pathway under normal situations. No stress, intramembranous ossifications. You'll have those Haversian cutting cones, and they'll cut, and then eventually osteoblasts will be laid. Right. Osteocytes and osteoblasts will be laid. So you should mention about these two, intramembranous and endochondral ossification, right? These are the two types of secondary fracture healing. Now, soft callus and then comes hard callus. During this stage, especially this stage of hard callus, wherein osteoblast differentiation is occurring. Osteoblast differentiation is occurring. This phase of hard callus. At this stage, you'll read about two markers. We'll read about them later on. BMP2, BMP7. Why have I mentioned only these two, BMP2 and BMP7, and not other BMPs? There are many other types of BMPs, right? 3, 11, 4, 1. Why have I mentioned about BMP2 and BMP7 only? Because FDA has approved these two only to be used. Now, BMP2 very commonly used in during what we call intermediary nailing of tibial shaft fractures. They have a drawback that they lead to formation of ectopic bones. But these two have to be remembered. You will have questions specifically on them as well. Short notes, write short notes on BMP2, write short notes on BMP7. More important is BMP2, right? So know what they do, whether they are osteoconductive, inductive. You should know the difference between these terms as well, osteoconductive, osteoinductive, right? There is another. I hope you know which term is it, the other one. Now, the examiners tend to, if you mention these terms, they'll tend to ask you more questions, more marks you'll get. Now they'll ask, name the agent that is osteoconductive as well as inductive, and also provides a scaffold for bone formation. So you should know them. I hope you are quite like you are well versed with now you are well versed with fracture healing, and how will you write your answer when a generalized question on fracture healing comes, or a question on a specific type of healing comes, right? Okay. Now I think I have to rub this. Yes. Now we have already discussed this part, hematoma, remodeled lamellar bone, right? Now I have given you this slide so that if you have any difficulty, you can maybe check it again, and that will help in keeping it on in your brain for a longer term. So you know what is the difference between what we call woven bone and a lamellar bone? When a woven bone is formed and when a lamellar bone is formed, this is not going to be asked in the MS or the DNB exam, neither in theory, maybe not in the practical, but you should know the differences. I hope you are guys are well read and you know the differences. Now, one more thing, yes, one very important thing rather. You should know what is the difference. You should know two laws. One is parents law, parents law of while there is a question on fracture healing or anything related to basics of fracture healing, you should mention these two law. Always mention these two law and highlight them. These attract the attention of the examiners. Parents law of interfragmentary compression. Most of you might have heard about it. There are three structures that we talk about whenever we talk about Parents law. It tells you how much the structure can sustain, how much strain the structure can sustain. Say bone, then comes cartilage, then fibrous tissue. Now, just asking you a question. Out of these three, which structure do you think can sustain maximum amount of strain? Please don't answer bone. It can only sustain 2% of strain. Cartilage 10%. And fibrous structures, that is 100%. Should know this Perrin's law. Should also know Wolff's law. Wolff's law is something that's basic to orthopedics and should be known to each and every orthopedic surgeon. Wolff's law. What is it? It's something we all know. Diffuser trophy. That is Wolff's law. Wherever there is compression, where there is force applied, there is new bone formation. If there is no force applied in a particular bone or region, there it tends to occur, the resorption tends to occur, and it eventually atrophies. That is what is Wolff's law. Right? Now, yes, what are the factors on which union depends? This is a slide that is, I would say you should take a snapshot of it. Maybe we'll discuss them this slide in slight detail, but there will always be a question on factors on which union depends. We all know the mechanics or the insights of the pathways of fracture healing. You should also mention about SOX 9, should mention about CRISPR. These are involved in the at the molecular or the genetic level of the fracture healing process. Now, local factors like if there is an open injury, Gustello-Anderson type 3, mention about the Gustello-Anderson classification, very important. Mention about the ISS criteria, very important. If there is infection, what will happen? Now, infections lead to there is bacterial spore formation. What even why? The question is, why does infection lead to non-union or compromise of the union? Because the host and the bacteria, they fight for one very important element, iron. Osteoblasts require iron, the bacterial cells also require iron. Whichever has a reduced iron out of the two, hypoxia occurs and eventual cell death occurs. So, open injury, infection, hypoxia will occur because of decreased iron supply, and it will lead to loss of union, right? Or delayed union or non-union. Periosteal stripping, while you are fixing a, say, shaft femur fracture, or maybe some other fracture, you are advised to do as low periosteal stripping as possible. Why? Now, here comes the concept of locking compression plates. Most of these plates are designed in a way then that periosteal stripping is not required. Earlier, the idea was strip the periosteum, apply the plate on the bone, dead end, and then fix it. Now, that led not to that better healing. Why? Because periosteum is the source of nutrition of the blood for the bone. If you're stripping the periosteum, you're compromising the vascularity of the diaphysis, right? So periosteal stripping is not advised. Avoid periosteal stripping while plating as much as possible. There are certain situations when you will require to do it, no issues with that, but avoid as much as possible. Yes, segmental defect. There is something called critical size defect. Remember this term, critical size defect. You can write in your exam as well, CST. What does it mean? If there is a defect more than 2 to 2.5 centimeter, very less likely that union will occur. You might very often encountered in humerus shaft fractures. What you'll require to do there, you'll require to abut the fragments together, apply a graft. Why? Now, the trick is there are two ways of doing. You might take these fracture fragments near, apply iliac crest bone graft, and then compress it, and then apply a plate. This has its drawback. Why? Because the graft tends to resorb. So the idea is abut the fragments together, right? And then apply the graft wherever the defect is. Even if the defect is large here, it doesn't matter much. And then do plating. Apply absolute, try to achieve absolute stability here, right? Now, if there is comminution or soft tissue crush injury, just like in open wounds, there is less likely to be fracture healing, optimum fracture healing, right? Now, there are certain fractures like scaphoid waist fracture, talar neck fractures, femur neck fractures, especially if the posterior vessels are compromised, right? Fifth, metatarsal shaft fractures, not exactly shaft, it's more near the base. Fifth, metatarsal base fractures, they tend to go more into non-union because these fractures tend to have compromised vascularity. That's the most important part. When will a fracture go into non-union or delayed union? When the vascularity is compromised. Now, these are the local factors. There are certain host factors as well. Smoking. What do you think smoking does? Carbon monoxide is released. It causes endothelial cell dysfunctions. These aromatic compounds are released. Endothelial cell dysfunction. Right. And what else? Smoking, very important. It causes denaturation of cells. It causes osteoblast apoptosis, diabetes, insulin-like growth factors, IGF-1, advanced glycation end products, right? These all cause osteoblast apoptosis. In diabetes, you also have increased neovascularization, that instead of supplying the vessels, supplying the bone, the vascularity of the nearby structures is increased, and hence the bony growth is compromised. Then you have anemia, decreased iron, right, and hence poor vascularity and hence hypoxia. Then you have low vitamin D. Vitamin D, low vitamin D, especially, yes, low vitamin D, especially if it's less than 20 per ml, right? Then you have steroids, very important factors. You should mention a few of them in slight detail as well because that attracts the examiners. What does the steroids do? It causes osteoblast apoptosis. It causes increased IGF-1. All these lead to cell death, right? You have NSAIDs, the COX factors. COX-2 pathway is activated. All these lead to compromised vascularity and hence cell death and osteoblast compromise or apoptosis and hence decreased union. Right. Now, it also depends on the treatment factors. Various drugs are also involved in causing non-union. You should know them as well. Now, treatment factors. As surgeons, these are very important for us. Fractures requiring absolute stability should be fixed in an absolute stable fixation modulus, right? Inadequate fixation or strain. If even if the strain is too high, you have compact, you have compressed the fractures together, and you have applied two screws that are very near the fracture fragments. Now there is no micromotion occurring. If there is no micromotion occurring, the union at the fracture site is likely to be compromised. Right. That is what overly rigid fixation also does. Then malreduction. Now, while you are fixing any fracture, say subtrochanteric femur, IT intertrochanteric femur fractures, try to achieve reduction first. The nail does not do reduction for you. Achieve reduction first, look with the help of a C-arm, and then fix the fracture. The nail is only the device for achieving 3-point fixation, providing stability, relative stability, right? Callus formation. It will encourage callus formation. If you think that I'm just holding it and nail will reduce the fractures, no, nail does not reduce the fracture. Remember this dictum, reduce the fracture, whatever device you use to reduce the fracture, and after reduction, put in a nail, right? Now, too much distraction, if we've just discussed critical size defect, 2 to 2.5 centimeters, if it's more than that, very less likely the fracture will unite. Too much distraction, the fracture will less likely to unite, right? So the rule for us residents is treat the cause, whatever the cause of non-union is. It could be systemic, it could be surgical, that is the way of surgery is not good, or it could be some other. Now we should know what type of uh, disunion, whatever you call it, is. It could be non-union, it could be malunion, right? You should know the difference between them as well. Now Delayed union is something, the healing is slow, but it is occurring. The process is occurring, though it is slow. Now, the more important than that is the definition of this. What does FDA say? It's been more than 9 months. The fracture has not united, it's been more than 9 months, and it's been more than or equal to 3 months when we have not seen any radiological progression towards the good side. I hope you are understanding what I'm trying to say. The whole duration has been more than 9 months, and it's been more than or equal to 3 months of achieving no progress. Before that, there was some progress, but more than 3 months of having no progress. That is what non-union is. Should know the difference. The examiners will ask, be it in theory, be it in practicals, right? So most likely these patients will present with, I am having persistent pain. A particular site you will have pinpoint tenderness. You might also, the patients might also present with loosening of the implant, right? And you'll see there is no progressive callus formation. There is a callus of on one plane only. No, four, all the four cortices have not fused. Even if two cortices have fused at times, you can be okay that it will heal, right? So clinical judgment is very essential. Very often you'll see X-ray looks like the cortices have not united, but the patient has no complaint whatsoever. Will you consider it even if it's radiographically a non-union, but the patient has no complaint? What will you do? Will you operate or exchange nailing or anything of that sort? The answer is no. You treat the symptoms, dear. You don't treat the X-ray. Now, types, you should know there is this called hypertrophic. What is happening? The biology is intact. There's something wrong with the maybe procedure of the surgical procedure that you have done, and hence it has gone into hypertrophic union. Now, this in itself is of two types: horse hoof, elephant. What elephant? Elephant foot. Yes. Then there is oligotrophic. Biology might not be good, but the union is not very good. The opposition of the fragments of the two fragments are not very good, and hence there is not adequate callus formation. Then there is atrophic non-union, where the biology is compromised. The fixation might be good, might not be good, but the biology is not good. So you have to do something about the biology, maybe a graft, maybe PRP, maybe something else, right? Infected, assume the fractures if in non-union to be infected until proved otherwise, right? Now, what's the treatment? How to very often the examiners, these are the static questions, the ones we have been discussing so far. Now the examiners are more interested in understanding or maybe knowing how do you think, how will you approach. So you should know the algorithm, at least know how to progress, how to proceed. So what will you do? You'll say, okay, sir, I'd like to get a complete blood profile of the patient, which will include ESR, CRP, the wound history, if there is a discharge, if there is a swelling or a synovial hypertrophy, I'd like to get a biopsy done, right? Now, before that, history, alignment, any gap, these alignment of the implant, whether or not there is any implant breakage, these are very important, right? Now, after that, you'll try to correct the mechanics, right? If there is a plate that is loose, if there is non-union because of inadequate weight bearing, you'll do dynamization, right? You'll do exchange nailing if required. If the fracture is malreduced, you will do re-reduction and maybe apply a bone graft, preferably from the iliac crest or the fibula, and then augment the fixation, right? The restoring biology is very important when their biology is compromised, especially in case of atrophic or oligotrophic non-union. You debride always and always whenever you're redoing a procedure in case of non-union, debride, ream. If you are doing a renail, ream, debride the fibrous tissue. The bone ends have to be freshened so that bleeding points are seen. You have to open the canal, you have to ream it, right? At times you might require to do RIA, RIA. I don't have that much time, but this topic is something that's going to be asked in the exams very soon. RIA. Graft substitutes, you should know autograft, allograft, they might be asked as a separate question. Now you have done the procedure. Now serial monitoring of the patient, serial radiographs is very important, right? So these are the way that you approach a case of non-union, right? So we have already discussed in hypertrophic non-union, what is compromised is maybe our fixation, right? Because the biology is completely intact. So Graft is not always required, but it is required in case of atrophic or oligotrophic non-union. You have to debride, you have decorticate, mascule procedure might be required. Mascule is more important for infected, yes. For critical bone defect, you might require to apply cement spacer, right? So that space control is very important. The systemic antibiotics, depending on the cultures, have to be given. Bone transport, this is very important because questions might come from mascule procedure. These might come for maybe short note. Muscular procedure is very important. Then bone transport. You might get question on bone transport as well. So my advice to these out of from this slide, remember the non-union treatment algorithm. Remember RIA. Remember muscular. Remember bone transport. These are the three topics, maybe four, on which questions are going to be asked in your exam. The static part, the fracture, healing stage, and everything, these are something that everyone knows. These are the things. Bone transport, masculine, RIA, non-union treatment algorithm. These are going to be asked in exams from now on. Right. Now you should know what are the augmentation options available with us. We have autograft, which are the gold standard. Why? Because it is osteoconductive, osteoinductive, and osteogenic. Now you're okay. Which was the first term? Yes, osteogenic. Yes, but donor side pain and all these these are the drawbacks, but I don't think these are that big a drawback. But one very important thing, always take consent. Whatever graft you are taking, you should always take a consent beforehand. Then comes the role of allograft, right? Devascularized bone matrix. Not much of a role in Indian settings because we generally do not do allograft unless and until the autograft is not something that we can use. Then only we think of allograft. Why? It's not osteogenic. It's very less osteoconductive. Only osteoinductive most of the times. Then there are synthetic substitutes. You have beta TCP. You have calcium phosphate. You have bioactive glass. Bioactive glass. Mention these three: beta TCP, bioactive glass, and calcium phosphate. The examiner expects you to mention bioactive glass. It's very important. Why? What makes bioactive glass a very important part of your answer whenever you mention about the augmentation options along with autograft, allograft, and the synthetic substitutes? Because other than being osteoconductive, it has antibacterial surface effect. So you might get a question on write a short note on synthetic substitutes that are used in case of a non-union. The question might come in this way. So you have to mention about calcium. You have in these questions, you have to initially mention about the osteogenic, osteoconductive, osteoinductive. Now, what are these exactly? Then you have to mention calcium phosphate. What it does? It provides a scaffold. It helps in osteogenic. It substantiates the autogenic potential. Then comes beta TCP. Resorption is a drawback, but it provides a good osteoconductive surface, right? There is bioactive glass. It's osteoconductive as well as antibacterial surface has antibacterial surface effect. Now, one of the most important things that help in osteogenic or osteoblastic differentiation are bone morphogenic proteins, especially 2 and 7. Now, 2 is osteoinductive. FDA has indicated it especially for acute tibial shaft fractures if open, right? Along with intramedullary nail. Used for skeletally mature patients, the drawback is ectopic bone formation can occur, right? Then there are biological augments as well. BMAX are being used, right? Mesenchymal stem cells are being used. PRP is being used. A lot of Chinese studies are there, but not much approved in Indian settings. More studies required to be done, right? These are some of the. I have taken a snapshot so that it will be easy for you to remember as a what we call table in a table form the various osteogenic, osteoconductive, and osteoinductive components and the mediators of fracture healing. So please read and go through this table once before you go for your final exam. Then this table is very important. The augments, biological augments, will be able to answer your question very well. Just like this, I had a question on this demineralized bone matrix in during my time in our exam. They are osteoinductive, they are osteoconductive, right? Now you don't need to mention the RCTs, and FDA has cleared them. That's why you are using this. Then there is BMP2. Then there is BMP7. BMP7, we just discussed a bit earlier. What is OP1? I think we didn't discuss it here, but BMP2 is also called OP1. BMP2 is known by the goes by the name of Infuse. Infuse, it's FDA approved. We all know by now. The one drawback it has is heterotopic ossification or ectopic bone formation, right? So these are the things you should mention about bone marrow concentrate, BMAC. Should mention about teriparatide as well. You should also mention about PRP, very important, very commonly used, as well as bioactive glass because of its antibacterial effect. Right? I think this will be all. You'll be very well if you go through all these slides and maybe watch this video lecture a few times. You'll be able to answer any question on the given topic. Thank you.